Hello. This patient underwent cataract surgery with IOL implantation elsewhere few weeks ago. The patient developed hyphema, raised intraocular pressure, and uveitis following cataract surgery. As we can see, the IOL is decentered inferotemporally. This is the right eye of the patient. The incision was given, SICS was done, and a foldable IOL has been implanted. Some cortical matter is there at on o'clock. Since this is a hydrophilic single piece lens with thick haptics, I thought this is the cause of UGACE syndrome. The Rexis or scan opener type. One haptic was in the bag, the inferior haptic, but the superior haptic, which is there at around 11 o'clock, it was outside the bag. So I plan to remove this IOL and implant a multi-piece hydrophobic IOL, 13 mm overall diameter, in the sulcus. A side port incision has been given at around 7:30 o'clock, and the cortical matter which was there at 1 o'clock has been removed. The viscoelastic substance has been injected into the antechamber. The IOL is dialed and the haptic is brought in front of the iris and it is taken out. The SICS incision has been opened, and through the same incision the IOL has been removed. Now I am irrigating and aspirating to see if some more cortical matter is there, and whatever hyphema was there, if it can be removed. I have seen the fundus of this patient and the retina is okay. Optic nerve head and macula is fine. So I am expecting good vision in this patient. Viscoelastic substance is sprayed over the epithelial surface of the cornea. It improves visibility. Now the IOL, in this case Acrisoft multipiece made by Alcon has been selected for implantation in the sulcus. This is a foldable IOL, but since it is going through the SICS incision, which is about 6 mm in size, I don't have to increase the incision. I don't have to use a cartridge to fold it and implant. It goes straight and it is deliberately placed over the sulcus, over the anterior lens capsule, both the haptics. Because if one haptic is in the bag and the other one is outside the bag, the lens will be a bit decentered, which is not desirable. So the IOL has been implanted and viscoelastic substance is now aspirated by a Simcoe cannula. The IOL is nicely centered, and I am expecting very good vision in this patient since the retina is in good condition. Now, such a large incision, about 6 millimeter or 6.5 millimeter, the SICS wound which has been opened again second time, I think it should be sutured, because the 6 o'clock and 12 o'clock meridian is going to be flat and the patient will develop astigmatism against the rule, plus cylinder in 180 degree, around 180 degree axis. To decrease the astigmatism, I have planned to put 2 sutures to close this wound, the SICS wound, with 10O nylon. Nowadays, the postgraduate students, junior doctors, they hate sutures, but it's not a thing to be hated. Rather, it is necessary. Suppose a patient comes to you with corneal perforation and you have to repair it. And when it is necessary, this suture should be done elegantly, should be done beautifully with utmost care. The incision site is being cleaned. It is irrigated nicely. This is the 10O nylon. And this is a suture being placed at around 12:30 o'clock. I used to do ECC in 94, 95, 96. For 5 years I have done ECC and IOL, and my practice was to put these sutures radially with optimum tightness, and my patients used to get very good vision with very little astigmatism. So surgery is more of an art rather than science. Yes, it is science, but we must be artistic. We must be having lot of love and care for the cells, for tissues, for the human being to do good surgery. We must think that this is me. Somebody is doing something on me, and how much care I would expect if somebody is cutting my eyes, and how would I, if I had been able to do so, how I would have done the surgery on my eyes. That feeling, that thought can give the impetus to do good surgery. This is another suture which is placed at around 11:45 o'clock, and this suture is going to close the wound. These 2 sutures are enough. Now this is how we place the knot. 2 loops, pull it not very tightly, on loop, pull it, and another on loop. 2 on in case of scleral limbal sutures, and in cases of corneal perforation it is 3 on 1. This knot is buried. It can be covered with conjunctiva, but sometimes it can pierce the conjunctival tissue and cause irritation, discomfort to the patient, which is not desirable. In this case, the conjunctiva was opposed by placing cautery. This cautery causes some burn of the cells and it retracts the tissues. In this way, it causes some opposition. And my practice is I don't like to burn even one cell. Rather, I put a releasable suture and oppose the conjunctival tissue. As we can see, the lens is nicely centered. The previous lens was decentered inferotemporally. So if something is not desirable, if there is scope, it should be rectified. In this case, the IOL was placed in the sulcus. A thick haptic IOL was placed in the sulcus. It has been replaced by a multipiece IOL, and I hope it will work well. Thank you very much.